We are live now, Chair.
Thank you. I'd like to welcome everybody to today's meeting of the Adults Health and Active Lifestyles Scrutiny Board. And I'm Helen Hayden, Councillor for Temple Newsome, and I chair this Scrutiny Board. So I'm going to ask board members to introduce themselves. I'll normally start with Councillor Anderson, but she has sent that she may be late to this meeting, so I'll introduce her when she gets here. So we'll go to Dr. John Beale, please.
Good afternoon, I'm John Beale. I chair Health Watch Leeds and I'm a co-opted member of this board.
Thank you. Councillor Brooks.
Councillor Kayleigh Brooks, Little London and Woodhouse Ward, and I'm substituting for Councillor Iqbal today as he's not very well.
Thank you very much for stepping in. I really appreciate it. Councillor Elliott.
Councillor Judith Elliott, representative for Morley South, and for the Outer South Committee, I am the Older Persons Champion.
Thank you very much. Councillor Harrington was hoping to join us at 1:30. Are you here? No, is she here? No, she was also. Councillor Knight.
Hello, it's Councillor Christine Knight for Wheatwood Ward.
Thank you. Councillor Latty.
Hello, Councillor Graham Latty. I represent Guiseley and Rawdon Ward.
Thank you. Councillor Lay.
Councillor Sandy Lay, Otley and Yeadon Ward.
Councillor Reagan.
Good afternoon, Councillor Denise Reagan, Bermondsey and Richmond Hill.
Thank you. Councillor Smart.
Hi there, Councillor Alice Smart, representing Armley Ward.
Thank you very much. Councillor Trustwell.
Good afternoon, Councillor Paul Trustwell, Councillor for Middleton and Belle Isle.
Thank you. And last but by no means least, Councillor Wenham.
Good afternoon, Councillor Wenham, representing the Wronghill Ward. Thank you.
Thank you very much, everybody. So if I could invite officers and those speaking to introduce themselves when it come to the items, that'd be lovely. So we'll go now to the first 5 items. Can I ask Harriet if you would talk us through those, please?
Yes, of course. Thank you, Chair. Under agenda item number 1, there are no appeals. Under agenda item number 2, there are no exclusions of the public today. Under agenda item number 3, there are no late items. Under agenda item number 4, can I invite board members to declare any disclosable pecuniary interests, please? Okay, I'll take that as none. Thank you. And under agenda item number 5, we've received notification that Councillor Iqbal has sent his apologies and Councillor Brooks is here today as substitute. And as you've already mentioned, Chair, Councillor Anderson and Councillor Harrington may be slightly late.
Thank you very much. Thank you, Harriet. And I would like, can we put into the minutes to send our best wishes to Councillor Iqbal for a speedy recovery, and our thanks again to Councillor Brooks. Also, another matter, can the board agree that should I have technical difficulties, that Councillor Trustwell will step in to chair the meeting? Brilliant, thank you very much. I'll take that. And thank you to Councillor Trustwell for being on standby. Okay, so moving on to item number 6, the minutes of the meeting of the 16th of September 2020. So can I have them approved as a correct?
Yes, Chair, move them.
Lovely, thank you very much. Any matters arising? No, lovely, thank you very much. Right, so we'll move on to item number 7, which is the Leeds Adult Mental Health Services. So for this item, we will have Councillor Charwood a little bit later. So we have Kath Roth, Director of Adults and Health, Caroline Barrier, Deputy Director Integrated Commissioning, Kash Ahmed, Head of Commissioning, Mental Health and Learning Disabilities for Leeds CCG. Caroline Townsend, Senior Commissioning Manager, Mental Health, Leeds CCG. Sam Prince, Executive Director of Operations, Leeds Community Healthcare NHS Trust. And Alison Kenyon, Associate Director, Leeds and York Partnership Foundation Trust. And Naomi Lonergan, Director of Operations, North Yorkshire and York, Tees, Esk and Wear Valleys NHS Foundation Trust. So I'd like to welcome you all here today. I'm thinking, is it Kash? Are you going to start the presentation, or is there anybody else who wants to introduce it first of all?
Yeah, it will be me. Myself and Alison Kenyon will take us through the presentation. Hopefully, Angela will be able to present, or will you be able to present, Angela?
Yes, I will, Kash. I'll just present the screen now.
Okay, thank you. Okay, so while that's loading up, so just want to first of all thank the board for the opportunity to talk about mental health, and I know we've got a number of items today, and we felt that it would be really useful just to have a quick overview of some of the challenges that we have in mental health as a result of the impact of COVID and the pandemic, and provide an overview of some of the key challenges, but also what the work is happening across the city as a response to those challenges. Myself, as the commissioning lead, and also Alison Kenyon as the operational lead within Leeds and York Partnership Trust, will just take you through a presentation. I appreciate there's lots of information there, so we want to obviously open up and have more questions and more discussions. So we will try to go through this as a high level and not go through each bullet point, because we'll be here all day. So we'll try to be succinct, a high level, and then we'll take some questions. So next slide, Angela. So in terms of impact of COVID-19 on Leeds Commission Mental Health Services, I think at the very beginning, at the height of the crisis that the country was facing, there was major concerns about NHS becoming overwhelmed, and it was a real stressful time at the time. However, it was a fantastic response across the city, across all mental health services. That's not just statutory services, but our voluntary community sector, to adapt services. Adapt services and actually work flexibly to manage the situation in terms of the crisis situation we were facing. In particular, the city and all the services enacted their individual resilience planning, which was to prioritise inpatient services, crisis and community services. And that happened right across the board, across all services. And face-to-face offer or face-to-face support was continued to be offered in those priority areas, and for people who needed face-to-face, especially in the first phase of the pandemic. Also services were also able to expand and scale up its remote support using digital innovation, digital platform. So that was a really fantastic kind of response from all mental health services and communities in its broadest sense. In terms of impact, what we saw was at the very beginning of at the kind of onset of COVID, there was a significant reduction of referrals and demand right across mental health services, similarly to what happened in primary care and also in the general acute hospital as well. So there was a reduction, but that reduction was only time limited. And what we have seen is impact or demand on mental health services has begun to increase. In fact, a lot of the services, the demand has been increasing ever since May and June. And so that's a key feature of this presentation, is that demand is continuing to increase. Also, what also has been reported is acuity. So a lot more people presenting with more complex acuity are presenting, whether that's in voluntary community sector or whether that's in community or inpatient. That has been reported right across the board. Just next slide. Okay, so in terms of the national picture, there's emerging evidence that there will be immense impact of COVID-19 on in terms of UK population around mental health and well-being, and some of the emerging evidence and prediction and modelling work indicates potentially there could be an increase with a surge in demand estimated at around 20 to 25%. So as a system, we've got to plan in a joined up way to ensure that if the demand does increase to that extent, we've got to have mitigation plans to respond to that. And again, a bit later on, we'll talk through what some of the specific plans we've got in place. What also has been reported, not just in Leeds but nationally nationally as well, is that there are some specific groups that have reported poorer mental health. Women, young adults, those people with existing mental conditions who perhaps were receiving support before the pandemic, and because of social distancing are having to cope through remote support as well. And also we were seeing people with lower socio-economic background, and also people having employment, their employment situation changing due to the pandemic. So these are some of the groups that have reported poorer mental health. And again, that's a challenge for the system going forward. Just next slide. Just want to very briefly talk about some of the achievements to date. So at the very beginning of this crisis, at the time, all providers, particularly the NHS Trust, Leeds and York Partnership Trust, as well as Adult Social Care and CCG, came together to look at how we can expedite additional inpatient discharges. So really be proactive around discharge, and something members will be aware is that discharges can be really challenging, especially with complex presentation. So one of the key achievements we've had so far is that we've been able to develop a really good integrated discharge process for older people as well as for people with working age adults, and that work has enabled a really good throughput of discharges. In addition to that, what we also did is, as a CCG, we also increased capacity, and in order to increase capacity around step down, so we purchased again more provision for step down provision in the community, and that again has had a really positive impact. Most of the services maintain to be open. They continue to open and operate, and offered face-to-face where it was required, but also were able to use digital options to provide remote support where it's required. We've also got so many examples in the third sector, how the third sector were very flexible in supporting statutory services and actually work collectively in supporting people who needed that support. So for example, we had Touchstone working very closely with our community mental health teams and actually offering practical support on the ground. And we've also had third sector really mobilising and working with local care partnerships around offering and providing welfare calls and really coordinating support at that kind of locality level. There's so much fantastic work has happened right across the board. And the other thing I would also mention here is that we also were able to expedite and actually develop a mental health support line, 24/7 mental health support line that we already had plans in place, but we're able to fast track that work as well. So these are some of the key highlights of the work we did in the first few months of the crisis. Next slide. So Alison will just take us through a couple of slides. Next slides, they're more around the impact and the data, what the data tells us around some of the service lines. So Alison. Alison, I think you might be on mute.
You just need to unmute yourself.
Sorry.
Oh, not at all. Thank you. It happens to all of us. Thank you. Welcome, Alison.
Thank you, and thank you for the invitation to come and tell you a little bit about what's been going on within Leeds and York Partnership Foundation Trust and with some of our partners that we work with. So I'm going to take you through some details around the services now. So I'm going to start with the Leeds Mental Wellbeing Service, which you will be aware that we work in a partnership led by Leeds Community Trust around delivering what was previously the Primary Care Mental Health Service and the IAPT service combined. So just to share some information around what's happened with that service, that we have seen referrals increase in recent months, and we can predict that that is more or less as a response to the pandemic. And the approach that's been taken on the IAP side of things, and Sam may want to say a little bit more about this, is that they've taken a digital first approach. So where we can, we'll do things via Zoom and platforms and an Appointments Anywhere platform that is becoming increasingly popular in the NHS. The primary care element of this service has increased its capacity during the pandemic. This was planned, part of the plan development and the recruitment phase of the primary care mental health teams, and now every primary care network has access to their primary care mental health team. And as you can see, we've seen an increase in referrals to those teams as the service is now fully rolled out across the city. Next slide, please. So with regard to the acute adult inpatient services within Leeds and York Partnership Trust, mainly based at the Beckland Centre with a couple of wards down at the Newsom Centre. Initially, we saw referrals into crisis services reduce. However, what you will see from this is in the main, our bed occupancy has remained the same. Where you see it dip is because in order to comply with the guidance that was being issued around COVID, we were asked to create what we called cohorting spaces. So groups of beds that we could place any positive service users with COVID in these areas in order to be able to isolate them and protect staff and other patients and service users from further infection. And in order to do this, we had to close some beds to create the space. And this accounts for the dip in the admissions, so where you see the red dots on the graph. However, when you see the next slide, you'll see that our out of area placements actually increased during this time. So the demand for beds remained the same. So if you could move on to the next slide, please. And this is the slide I was talking about. So you can see in the graph on the right-hand side that the increase in demand, particularly around July, for out-of-area placements was some of the highest it's been in the last number of years within Leeds and York Partnership Foundation Trust. And unfortunately, we had up to 30 people at one time placed out of area, which is not an ideal situation to be in. However, as the rate of infection reduced, we returned those cohorting beds to their normal use, and we have seen that we've reduced the out-of-area placements significantly. And as I speak to you today, we currently have 12 people placed out of area, and that includes for psychiatric intensive care units as well as for acute inpatients. We have seen our delayed transfers of care increase during this time, sadly, and part of this is due to some of the delays in pulling care packages together and in awaiting specialist placements, and these have been impacted on by the pandemic. Next slide, please. The point I wanted to bring to your attention on this slide is not necessarily the rates of detention, which surprisingly to us have improved over this time, but is to the first paragraph. Now, unfortunately, because we moved to a new clinical information system in April, we've not been able to get comparable data from our previous system in relation to this, but we are aware that during the last 6 months, 38% of our admissions have had no previous contact with mental health services, which is quite surprising. We normally have a much higher percentage of people who are known to services in our inpatient beds. So this leads us to think about the infrastructure in the community and support structures that people had that haven't been there during this time. We've also seen an increase in people who have previously been very well and stable with their mental illness and have managed it with the help of their GP or community support services that have had no contact with us within secondary care mental health services for over 12 months. And we've seen a significant rise in people relapsing and requiring an admission. We have found the acuity of our admissions has increased significantly during the pandemic. And again, this leads us to think about the infrastructure in the community. Next slide, please. Initially, as Cash alluded to, our referrals into services decreased. And you can see in the graph here on the right-hand side, the number of referrals into the crisis team. So CRIS stands for Crisis Resolution and Intensive Support Services, which is the reconfigured crisis service that I believe came to Scrutiny probably last year or maybe even 2 years ago now. What we have then seen is once we started to I think raise the profile that mental health services were still very much open and there to support people, we've seen an influx of referrals, and we've seen a large increase, as you can see, in the numbers of people requiring support during a crisis. And as you can see with that graph on the right hand side, you can see that we've had significantly more referrals during the last few months than we've ever had into the crisis service. We showed data back to October 9, 2019 there. Next slide, please. So we also, as you're aware, have an acute liaison team in the emergency department with Leeds teaching hospitals. And they've been very busy during this time. Again, there was a drop-off initially. We supported the team by LTHT by moving out of the emergency department and recreating space for the liaison team in the Becklin Centre. We have seen that this has led to it being more challenging for us to achieve our 1 hour target of seeing people within 1 hour of referral. And we are encouraging as many service users as possible to come over to the Becklin Centre to be seen, rather than taking the space in the A&E department, which allows then for safer practice and cohorting spaces into hot zones within the A&E departments. But we continue to work very closely with LTHT to ensure that we're able to support them, as they have recently seen an increase in the number of people with mental illness admitted to acute beds. So we are making sure that we are receiving referrals for each of those individuals and providing the supporting as necessary. Next slide, please. We have seen in our community services initially the drop-off in referrals, but again, as you can see, that those levels of referrals are now returning to previous levels. I think the point on this slide to point out is that we have done some amazing work with Touchstone community support team, where they've supported us and helped us in providing support to what we call our amber service users. So these are people who are still quite high risk and need quite a lot of support, but it's enabled us to manage and keep those individuals safely at home with an appropriate level of support. The speed of which we were able to come together and develop and implement this service has been phenomenal, and I'd really like to thank the work that Touchstone have done in supporting us to achieve this. It is now an embedded way of working, and one that we would want to retain in the future. We have increased in a lot of our services the digital offer, as Cash has pointed out, offering face-to-face interventions where people don't have access or where it's clinically appropriate to see them face-to-face. We've done a lot of work over the telephone and again using video conferencing. I'm going to pass you back now to Cash for the last few slides.
Thank you, Alison. That was great.
Thank you. So just a few more slides here, which is one specifically want to mention third sector and the role of third sector. I think Leeds has been really fortunate. We've in particular around mental health, we've had a very diverse and quite a rich kind of offer from third sector. We've a range of providers that offer crisis support, accommodation support services, employment for and peer support services. And again, those services have played a significant role in the overall response to the crisis that we have been facing and the challenges posed by COVID-19. Want to specifically just mention again, a lot of the services have been able to develop digital offer. A lot of the third sector perhaps didn't have the infrastructure, or some did. Some of the infrastructure was underdeveloped, and again, as a system, we've been able to support some of those requests and actually offer, and in fact, actually, some of the providers will say that they've been able to reach other groups that they would probably not otherwise be able to do without the digital infrastructure, or the digital option. So that's been really fantastic. And then also just some, also all of the services are currently looking at how they can offer face-to-face, but within the social distancing guidance. And that is really challenging because space and estates are quite limited and it's really complex. Having said that, we've had, for example, Dial House have been offering coordinated opening times to access face-to-face where it's required. So that's been really good as well. And just overall, there is more work happening across the system, but also with third sector partners to look at how we continue to reset services as part of the phase 3 of this crisis. Just next slide. Again, I think there's been significant work happening with supported living and care homes. There's constant communication with all of the providers, and ongoing regular communication through our adult social care colleagues around care homes and any support they need that's being communicated. I have to say, care homes and supported living providers have done fantastic work around supporting discharges. So the work that I mentioned earlier on, those discharges would not be possible without the commitment from our care homes and supported living providers. And we continue to work with them. We continue to look at what the pressures are in that sector and how best to support those individual providers. So that's been really good. Just next slide. We recognise that during these current times, we recognise that the impact on carers has been significant, and more pressure on carers around caring needs and so on, especially where services have had no choice but to close. We also recognise that there's been also more challenges for carers on loneliness and isolation. However, there is more work happening, in particular carer leads. I continue to keep in touch with carers, providing one-to-one support through a range of different forms and means. whether that's telephone, email, and other digital platforms. And also befriending support is continuing as well in terms of carers support. We've also, there's also launching of a new digital inclusion of inter-support for carers grant scheme, which again aims to mitigate loneliness and isolation and during this winter as well, which has been administered by Carers Leeds. So again, there's more work happening around our carers who do an absolutely fantastic work on a day-to-day basis. Next slide. Just want to highlight very quickly, as part of our response to mental health response, what we've done is set up quite a small, simple governance structure just to ensure that we have oversight of how the overall mental health system is coping with the pressures and the impact of COVID. And we have a number of subgroups that actually meet as a system. Collectively, we meet on a call to, looking at what can we do more around prevention, what's happening in our acute and crisis pathways, and also around older people and dementia subgroups. So we have these constant regular conversations on a fortnightly basis, making sure that operationally, but also as commissioners, ensuring that we are doing everything that is possible to support the pressures that we have got in the system. And then also we have set up an oversight group where if we do need to escalate and we do need to make quick decisions, we can escalate and actually have those decisions made fairly quickly as well. So that's just a quick governance. Just next slide. Okay, this one is just really about the next steps, and there's a lot more work we need to do as a system. So we continue to look at forecasting for demand and capacity and really get a much clearer picture around what the demand capacity might look like over the, we're already seeing a 10-11% increase of pressures in most of the services, including our mental health act assessments are increasing. So again, we have got a number of workshops planned with all the providers to look at how we collectively understand our demand and capacity pressures. We continue to look at reducing pressures on inpatient crisis services. I often we look at all of our, how can we prevent, reduce and delay people needing crisis and inpatient services. So looking at all of our preventative and hospital avoidance schemes and making sure that they are fully optimal, also within the current guidelines, and ensuring that work continues. We also want to, as a system, we continue to work with our third sector, helping us to understand specific communities around health inequalities and ensuring that there are tailored responses to specific localities as well. So there's a lot of work happening in terms of our reset and stabilisation priorities. I won't go through all of those, but you can see there's a lot happening at the moment in terms of that reset work. Just next slide. Again, Alison, do you want to just very briefly cover the next two, which are more related around winter planning? And
yes, I will do. Remember to take myself off mute. So in order to ensure we're ready for the winter and to support the system with the available capacity, we've looked at adding in some additional capacity into the intensive home treatment team for older adults, and around working across the ICS across West Yorkshire and Harrogate to look at how we might increase additional bed capacity, particularly when we have outbreaks of COVID within our inpatient wards. So as an example, we recently had an outbreak within one of the Leeds wards, and I know Bradford at the moment has an outbreak, and we need to reduce admissions into areas and stop admissions into the affected areas in those situations. So we are looking at how we might work with the independent sector and develop proposals to work more jointly with our West Yorkshire colleagues over the winter period. We've targeted additional support into crisis and the liaison psychiatry service to support the emergency department at LTHT. We'll continue to work with third sector colleagues. And we have revisited all of our plans to ensure that we are able to flex our capacity and our response as the situation remains fluid for the foreseeable future, really. Next slide, please. Do you want to talk to this one, Cash? Do you want me to?
Yeah, I can. I think this is the final slide, so I'm happy to wrap up now. So, again, you know, what we've got plans in place later this month, which is to have a community system planning workshop to look at all of our capacity and actually do some scenario based planning. So what do we do as a system, as a city, if you know, based on different scenarios. So making sure that we've got all plans in place operationally, but also from a commissioning point of view. Continue to use all the resources and expertise that we have in the system around intelligence, around modelling and inform demand and capacity, which is very difficult and challenging to do in normal circumstances, but with the current circumstances, it can be very complicated. So we've got to look at different kind of scenarios that may play out over the next 6 months. Again, also, as Alison mentioned, we're specifically also looking not just at the demand around COVID, but also the demand we're going to likely to see during winter. And try to triangulate that information. We continue to work with our third sector partners around in terms of how we can mobilise and respond more effectively over the next 6 months. And the final point I would also mention is that between CCD and local authority adult social care teams, we've got a programme of work around developing supported accommodation, supported living provision in the city for people with complex needs. And we've got 70+ units of accommodation planned for the next 6 months, which is, again, will play a huge role in that flow in and out of the health and care system. I think that's the last slide. Angela will confirm. Okay, so thank you. Happy to take any questions.
Thank you very much. But to both Cash and Alison, and the sheer amount of work that's happened over the last 6 months. The IAPT recommissioning, which you've been quite a few times, just want to say publicly that it was a really innovative and well thought out piece of commissioning. And the work with the third sector, with partners in the NHS, was just exemplary, as was the consultation. It was done early, it was done widely, and I'd like to you know, thank Cash and all the team for you know, a brilliant piece of work. And it was really timely because you were up and running with partners when we were hit by a global pandemic, which nobody was expecting, and it's already gone digital in terms of the services you offered online. That was really insightful. Can I invite Caroline Barrier and Sam Prince if you wanted to make any comments on that, on the report, and Naomi as well, following on, if you want to make any comments on the work in Wetherby. So Caroline, would you like to say anything first?
Thank you very much, Councillor Hayden. I'd just like to say that we're starting the progression at full force in relation to the all-age mental health strategy. We've got clear governance processes to do so now, as is outlined in the report that was submitted. One of the reports that was submitted, and we've got a process whereby we've got senior responsible owners for each of the 8 priorities who are pulling together the work to ensure that we meet the requirements set out and identified in the strategy, and to keep an overview of its implementation. That will then report to the Mental Health Partnership Board, which is a board with a wide range of stakeholders and service user and carer representation as well, to ensure that we are absolutely keeping on track and informing of the progress we're making. And ultimately that reports to the Health and Wellbeing Board. So I just wanted to add that point, really. Thank you.
Thank you. Sam, would you like to add anything?
Thank you, and thank you for your kind words about the mobilisation of Leeds Mental Wellbeing Service. There's nothing quite like a crisis or a pandemic to give momentum to things that you are intending to do. And so I'm really proud of this service that's across both LCH but all our partners as well, in the way they embrace the move to a digital first approach to the service. So whilst we had a concerning dip in referrals at the beginning of the pandemic, I'm pleased to see that that's recovered now, and in fact we're seeing far more patients than we were. So that's great. The short dip in referrals gave us an opportunity to really review what we were doing, and again pleased to say that whereas at the start of the pandemic we had up to an 8-week wait for access to service, it's now a week. So we've been able to do some of that developmental work. So, you know, sometimes you get opportunities when crises come along to do things differently. So I think a challenging year ahead. I'm hoping that we're going to be able to maintain the increase in the numbers of people accessing the service, and we'll continue to innovate.
Thank you. Yeah, and the work done with Touchstone, I mean, yeah, there's nothing like a crisis to, but that just showed the strength of relationships and the strength of the partnership and how innovative, you know, the whole team is across Leeds in terms of stepping up really quickly and getting things done really well. Can I bring in Councillor Charwood before we go to Naomi, see if you've got anything to add. Welcome, Councillor Charwood. Thank you.
Thank you, Chair. Thank you, Councillor Hayden. Sorry I was a bit late. We're dealing with some NHS West Yorkshire-wide issues, obviously, at the moment, so I had to chair a panel there. I just wanted to very quickly add a bit to the strategy stuff about, just so members are aware, and I'm sure you are, but just worth reiterating that the mental health strategy has been something which we've led on from the Health and Wellbeing Board, and in my role as exec member, I've really pushed, as obviously I'm the mental health champion as well, so I've really pushed for this one approach across the whole partnership. You know, we have got a good partnership, but I think mental health is one of those things which has been historically quite bitty here and there, and we wanted to really pull that together so that if you need mental health support wherever you are in that continuum, you get a sort of hopefully a seamless transition between different sorts of services from the community sector right up to acute and back again. And also you might get support from your friends and family in an asset-based community development sort of way as well. And that we really pull that partnership together for people with mental health difficulties. So I'm really proud of it. Everyone's done a huge amount of work. So I just wanted to add that point to your glowing remarks as well, Councillor Hayden.
Thank you. It is going to be really challenging, and I think what this pandemic has shown and the lockdown is that people who were managing and were doing okay, yeah, it's very challenging for everybody. You know, everybody suffered in certain ways over the last 6 months, and you know, if you could pass on to all the staff, because they will have suffered as well during this pandemic, and you know, but they were there for other people to help, so that's incredibly good. Can I welcome Naomi Lonergan, who is from the Tees and S Valley, who basically look after adult mental health services in Wetherby, in that part of the Leeds. So would you like to add say anything about your part report on the work done in Wetherby? Thank you, Naomi.
Thank you. So I'm Naomi Lonergan, for those that haven't seen me before. I'm Director of Operations in North Yorkshire and York, the Tees and Wear Valley. And really the report is a summary progress update on the transformation of services for Harrogate and Wetherby that we came and reported on in January earlier this year. I think the first thing I'd want to say is just reflections of the presentation from Leeds, the themes around pressures on urgent care, admissions, acuity and so on is something that we have also seen and recognised across Tees and Wear Valley. But in particular, I suppose in relation to the transformation, the report just summarises and highlights that despite the pandemic, we were able to complete the building of a new hospital, and actually we were able to bring that forward. which was a real risk to us at that time. In the middle of a national lockdown, we thought it would get to a certain point and supply chains and contractors would be so affected we couldn't do that. So full credit to all the staff and to our partners in delivering that. We've been able to implement some of the community changes despite the pandemic, and in older people's, I suppose I would draw attention to the fact that we've reorganised the community teams around GPs and primary care, which again I think is a strength in the current situation that we're in. And in adults, we've been able to recruit to the post to strengthen our crisis response. And in relation to COVID itself, we have created an all-age 24/7 free phone helpline for the whole area, which has been very well utilised at the moment. So there's been some key strengthening. And outside of the transformation, it's not referred to in the report, but actually acute hospital liaison services were also invested in and heavily strengthened earlier this year, just before COVID hit. So that's really positive for all of our populations that require our services. In terms of inpatient admissions, concerns from the engagement, public concerns around engagement, particularly focused on older people with organic needs and them receiving inpatient ambitions. We have had low numbers of admissions from the Wetherby population, which is positive. But we did have an impact from the cohorting that Leeds colleagues have also described and explained. So on admission, older people did need to be admitted to a ward in Cross Lane Hospital so that we could manage that safely and effectively. But we're currently in the middle of works so that all patients admitted from the Harrogate and Wetherby area would go to their home ward straight away, regardless of the cohorting. And we're also looking to increase our capacity for COVID positive patients across the patch as well.
Thank you very much.
There's a theme here of the administration.
I think somebody needs to mute. Is that Councillor Anderson?
Yep, sorry, I can't.
Thank you. Not at all. And welcome, Councillor Harrington and Councillor Anderson. Thank you for joining us and welcome. I'll let you introduce yourselves if and when you want to ask a question. Thank you. Thank you very much, Naomi. That was and to get a hospital up and running in a national lockdown in the middle of a global pandemic was quite an achievement. So well done. So I'll go to questions now, and I'll start with Councillor Brooks. Thank you very much. And then I've got Dr. Beale, Councillor Lay, and Trustwell. So if you do want to ask a question, please do the raised hands. I'll put into the chat. Thank you.
Thank you, Chair. It's regarding more than the sort of service side of things. It's regarding the people presenting in the first place. So I sit on the Light and Lead Student Medical Practice LCP, and we saw some more recent data, and it's showing that there isn't the expected increase in people presenting with mental health problems. So I'm just wondering what's being done to reach out to those people that might need that support, because yeah, I was quite concerned to see that, because you'd expect with that those two sort of demographics that there would be an increase. Thank you.
Thank you. I don't know who wants to, and more about the fact that people might not be coming forward who should be doing. I don't know who wants to take that.
I can respond to that, Chair.
Thank you, Cash.
Okay, so I think the possible factors of there has been the demand from the Leeds student medical practice has reduced, and possible factors are because people were at the beginning of the pandemic, the people were either at home or there was a social distancing criteria was much more stricter. I think you know, so it depends, very much depends on the period of the data that you're referring to. You know, so I think what we now some of the information we're getting now is that the increased demand on primary care is beginning to increase. there was an overall reduction in demand on primary care and also secondary care services at the beginning in the first few months of the pandemic. When overall, I think what we're now seeing is an increase. In terms of what we've got in plans is that the universities have specific mental health support services in place that they've commissioned and developed themselves as a university would do. But also they have close working arrangements with Leeds Student Medical Practice, as well as working with community mental health teams. So and so there are arrangements in place. In addition to that, when we've commissioned the new primary care mental health service, the Leeds Mental Wellbeing Service, we've also got primary care mental health practitioners, effectively mental health nurses co-located and part of the Leeds Student Medical Practice as well. So there are a range of offers either through the primary care, but also there are also offers and supports through the university. But again, what we have to do is keep a close eye on the demand and see how we can respond to that going forward.
Thanks, Cass.
Thank you.
Come back. Sorry.
Yeah, sorry. I've noticed that Sam had her hand up. Did you want to come in on this, Sam? And then Alison, did you want to come in as well? Yeah.
I definitely very much what Cash said, but I think there's also the increase that we've seen in self-referrals and people going straight through into Leeds Mental Wellbeing Service. So I think we need to look at it in the round, but you're quite right, we need to keep a careful eye on, are there any groups that aren't accessing the service, and look at what actions we can take to bring them in.
So part of the community wellbeing reset group that showed on the governance structure, we are looking at how can we encourage people who are experiencing problems to come forward sooner rather than leave it. And this is certainly something we've experienced, as I showed you in the data from LYPFT, that people are coming forward very late in their presentation and often requiring admission then. So if we can encourage people to come forward sooner, there's an awful lot of help and support that is available to people. So through that reset group and work that's being led by Caroline Townsend, we are looking at working with our communication colleagues and media campaigns and other opportunities where we can raise the profile about seeking help sooner. So I don't know if Caroline wanted to kind of make a comment on that, but I am aware that we're participating in that work across all of the organisations.
Thank you. I think Caroline indicated, didn't you? Thank you, Caroline.
Yeah, I mean, Alison's covered much of what I was just going to pick up, but yeah, just to add that is certainly something that we're looking at as part of like the comms work stream that we've got ongoing, and also a sort of linked prevention work stream in terms of making sure that people do come forward for help or get that early support when they need to. So in the slides that were presented, I think there was the reference there to the fact that we want to do quite a focused comms campaign around winter wellbeing, where we'd hope to pick up some of this, including a focus on what people can do for themselves to look after their own mental health and well-being, but also reiterating that the services and support are there for people who need them.
Thank you. Councillor Brooks, that was a really good question. Thank you. Would you like to come back at all?
Yeah, I know the later answers were a bit more generalised, but I was asking about the Leeds Student Medical Practice and also the light. So, and obviously those two surgeries have very, very, very different demographics. So, so in the light, there's almost 50% of people from a BAME background. So I was concerned that perhaps people from a BAME background, and excuse me for lumping them all together, it's just the data that I was given. So yeah, concerned that people from a sort of BAME background don't less likely to present with mental health issues. So yeah, is there anything that's being done around that, or is that just coming under the comms?
So
I don't know if anybody can answer. Caroline, did you want to come in? Or whether we could have ask colleagues to have a look at that data in particular and get back to us later. But if Caroline and then Cash, I think you've indicated that, yeah.
I'm happy to have a look at the data being mentioned, but just to say that looking at inequalities is a key area for a number of our work streams, which we're looking at, including the comms, but wider. Although, yeah, I think it's fair to say there's more work to do about that. Something else just maybe worth being aware of as well is that we do have a regular student mental health forum that meets regularly with representation from Leeds Student Medical Practice, the Light, but also the university mental wellbeing teams. So yeah, we have been having that regular conversation with them about, you know, what's happening and what we can continue to do around the student population, but also I suppose with that representation of the two practices there, them feeding in what the issues are from their point of view. Hope that helps.
Thank you. Cash, did you want to?
Yeah, just finally, just to say that I think in terms of BAME communities, we recognise as a system, as a society, that there are specific inequalities and disparities relating to some of the BAME groups, and especially in the context of access to mental health services. And as a result of that and the feedback that we received through the engagement that we undertook to formulate and develop our new mental health strategy, I think one of the key priority areas is around improving outcomes and access for BAME groups around mental health services. So there is a work stream that is being developed, and there will be a clear delivery plan, a multi-agency delivery plan to look at the specific gaps and the data to help us to ensure that we have got an overall plan to respond to those some of those challenges around diverse groups, as Councillor Brooke has mentioned. So there will be a comprehensive plan being formulated as part of that strategy delivery plan in the next couple of weeks and months ahead, so we can share some of that detail again, and also anything specific around the student medical practice. More than happy for myself and Caroline to be contacted to analyse any data, to look at anything specific in more detail outside this board meeting.
Thank you very much. And I'll bring Sam in again, please. Thank you.
Thank you.
Good,
so this is something that's really important to the LMWS partnership. In the year to date, 18% of people accessing LMWS have identified from a BAME background. It's something that we're keeping a really close eye on. And some of our partners are particularly skilled, Touchstone, for example, at reaching some communities that statutory services haven't accessed previously. So it is something that we obsess on actually at our partnership boards as to how we can bring more people from disadvantaged groups into the service.
Thank you. Councillor Brooks, would you like Cash and Caroline to have a real look at that data and get back to us? Is that a way forward?
Yeah, that would be brilliant if possible. I know that you're very busy, but obviously,
but it's very important. It's very important.
Yeah. Thank you.
Lovely. Thank you very much, and thank you for those. The selection of answers there and the detail. We really appreciate it. Thank you. So I'll go on to Dr. Beale, please.
Thank you, Chair. Two questions, if I may. One of the things the media have picked up during the whole process of COVID has been in care homes, and the issue about family carers not being able to see their loved ones. And that has resulted, of course, in certainly an increase in the mental health issues of the family, but also undoubtedly of those in the residential home themselves. it is addressed in one of the slides. Providers have developed risk assessments. I'm sure a lot of work has been done on that over the summer period. Created space indoors and outdoors for secure, separate visiting space. Well, indoor okay, but outdoor is going to be less and less possible, particularly for older and frail people, and provided PPE for visitors. So I suppose the question is largely to Kath rather than to the CCG. Can we be pretty confident that should we go into tier 3 or a complete lockdown, that the situation will be better in the future than it was in the past when we were in unknown territory? But at least we have had an opportunity of trying to find a way through the worst of those problems. And I know it's a difficult issue, but we do need to minimize the mental health issues. And the second, if I may, Chair, relates to a very particular group, and that is prisoners. A very high proportion of prisoners already have, when they go into prison, mental health issues. And I'm quite sure that if what we read in the papers of the increased number of hours that prisoners are being locked up in their cells, their level of mental health will have deteriorated from what was already not good. I suppose it may be Cash or whoever, has the prison asked for any additional support for the mental health issues amongst the prison population?
Okay, so so Kath, did you want to take the first one, or and then I'm not sure who will take the prisoner mental health one.
That would be me, if that's okay.
Okay, yeah, that's great. Do you want to go ahead then now?
Yeah.
Okay, thank you. This is a very difficult issue, but you're absolutely right, Dr. Beale. We are in a better situation of knowledge and what we can do to mitigate the risk than we were in March and April. At that point, the level of asymptomatic presentation of the virus wasn't known, and so people were being discharged from hospital thinking that was the safest thing to happen. As we know, hospital-acquired infections do occur even before COVID. And also the PPE protocol at that point in March and April isn't what it is now, which is a much higher level of PPE protection. We are very clear that the national guidance isn't a blanket ban. It does not mean because you are in an area of intervention, which we now are, and probably rapidly heading towards a tier 3, I suspect, that means no visits. We are very clear that it has to be on a risk-based process, and that there is a material difference between window visits, for example, and actually crossing over the threshold into the home. So the guidance that we have issued to support care homes in their decision making is to do an individualised risk assessment. And it's not just the risk to the individual, but it's also the risk the visitor presents. So we have some family members who might work in higher risk occupations compared to others. And so perhaps when they talk amongst their family, extended family, they might be wiser to nominate somebody who is in a less risky profession than, say, somebody who works in health or social care. We are asking homes to look at the harm that is caused to the individual by not having a visit versus the potential harm that could occur should they acquire COVID and what their personal health circumstances are. And it's that defensible decision making that we're asking the homes to consider. They are quite rightly extremely cautious about letting people over the threshold for very understandable reasons, because we saw in March and April how absolutely devastating this disease can be for older, vulnerable people. So what I would say is there is no one right answer. we are trying to encourage an enabling approach, but ultimately the decision is that of the care home and the registered manager, and they walk a bit of a tightrope about what is the right thing to do. And I'll leave it there.
Thank you. Yeah, it was actually really detailed and it cleared up my understanding there. Cash, would you like to answer the second question, please?
Yes, so we've not had any specific requests from prisons or in regards to needing further support or mental health support specifically from that sector. Although we're in constant contact with the criminal justice sector around supporting people who are being released. So there's been no specific request. However, what I would say is that we have a range of universal services in place. So, for example, we've recently commissioned the mental health support line, which is 24/7, and anyone can access that. But also, if the support line feel that someone needs a primary care offer or a secondary care mental health support offer, then they can actually transfer the calls to the relevant service if required. And so we have got a universal support line, but also we've commissioned Leeds Mental Wellbeing Service, which is obviously IAPT, but also primary care mental health team across local care partnerships. So that's also available in addition to the secondary care offer. However, again, if we've, but what we can do is be proactive, and again, we have direct contacts with the prison. So, I'm more than happy to contact and just continue to see if there is any further support we can offer as a mental health system. I do think what will play a key role is a communication strategy to really remind people the services are still open, are open and available. And that marketing communication strategy will hopefully ensure that people that are not getting that support, the messages can get out to them to seek support much earlier on in the pathway as well.
Thank you. Dr. Beale, would you like to come back? Because that's a really important question about the prisoners as well.
Well, no, just to say that, I mean, they are two difficult areas to address. And I mean, the reassuring thing is from both Kath and Cash, to pronounce them, not get the words muddled, that they are on their radar, and that as we proceed, they will have to be flexible and do whatever is necessary. So thank you very much, both of you.
Yeah, thank you, because I had in my mind that there was a blanket ban on visits to care homes, that, and it's really useful to know that it's actually not a ban, as it were. Thank you. Councillor Lay, can I bring you in? Thank you.
Thank you. Yeah. I first of all want to thank everybody for the great work that's been going on in these difficult times. There's clearly an increased need at the moment. My three elements really are usual, sort of around the money, around service users, and around the secondary care really. So the first thing is large increase in need, projected increase in need. Have we had any extra money from central government to do these things, or are we working within the same budgets but being expected to do significantly more? Secondly, lots of talk about digital first, etc. Have we spoken to the people who use these services? Because I know from my own family's experience and my young, and some of you will know this, but from my young daughter, my daughter's experience, Zoom doesn't work for everybody. And it's not just about being digitally connected that it don't work for. It's for some people, they need that sort of face-to-face input. And so I just wondered whether we'd done some work around asking service users, because actually the pandemic has driven some of this digital stuff, of course, around social distancing. And secondly, we talked about the presentation talked about cohorting, and not just about cohorting patients who are positive, but how is there a reduction in the inpatient bed base because of the need to socially distance? So in my own hospital, of course, in secondary care, I've seen a reduction in the number of inpatient beds, because instead of having 6-bedded bays, and some of you will have heard me go on about this before, Councillor Trustwell, 6-bedded bays, we now have 4-bedded bays. Is that the same happening in mental health services? So when we look at the bed occupancy rate of nearly 100%, where do we think those additional beds are going to come from if we have less beds because we're having to socially distance people? They're my 3 questions, but mostly I just wanted to thank you for all that you're trying to do and continuing to do.
Thank you, Councillor Lay. Alison, shall I bring you in first?
Yeah, thank you. So in terms of the, I'll take the digital and bed numbers issues. The digital platforms that we have service users accessing, you're quite right, they don't suit everybody and they're not suitable for everybody, and actually they're not available to everybody. So it's a new way of delivering therapy treatment for a number of our service users and for our staff as well, actually. So we have within Leeds and York Partnership Trust been undertaking research and evaluating by asking service users for their input and getting feedback. We're also looking at the clinical outcomes of the effectiveness of delivering treatment this way as well. We're participating in a number of national studies as well as undertaking local research because this will inform whether this is a suitable way of delivering treatment going forward or not. Also, we are trying to accommodate everyone's needs. So if someone isn't able to use digital technology or it doesn't work for them, then they are able to access choice and choose a more suitable route. And as we've opened up and kind of reset the volumes of services that we're delivering an increasing amount now within our buildings, as well as offering home visits, as well as maintaining the digital platforms as well. So I hope that answers the question, Councillor Lay, that we are looking at the effectiveness and people's choice about accessing treatment by different ways. If I move on then to look at the bed numbers and the impact that COVID is having on there, this was the cohorting work I was talking about. Within LYPFT, we are in the main in the fortunate position of having individual bedrooms for most of our service users who are inpatients. And what that enables us to do is maintain social distancing without having to reduce the bed numbers. So we've not actually reduced the bed numbers now. We have created some additional space by moving some of our services around to open up a ward within the Mount where we can isolate people again on within individual bedrooms. Isolation is rather challenging because most of our facilities do not provide ensuite and have to share bathrooms, so we have to create spaces. So we don't always use our bed capacity if we have people with infections in the hospital, but we've not actually had to close any beds. So I hope that answers that question for you. And if I may take the liberty, Chair, to respond to the question in the chat about the prisoners.
Thank you, yeah.
Phones. What I will say is NHS England commission a specialist mental health service for prisoners. So each prison has a mental health team attached to it. Now, I'm not quite sure who provides the service any longer in Leeds. It is a private provider, I believe, but we do link in with the prison service and if need be, we will take prisoners into the acute beds within LYPFT or other specialist facilities.
Yes, I think that came from Councillor Harrington in the chat, and so thank you for that question, Councillor Harrington. Before I bring in Cash about the finance answer, would you like to say anything, Councillor Harrington? No, you're okay. Oh.
No, it's fine. Thank you very much. I just wanted to make the point that there is a phone line, but it wouldn't be accessible to prisoners.
No, that's true. And thank you, Alison, for picking that up. Cash, would you like to come in on the finance?
Yeah, so finance, nice and easy question that. Okay, so far as during the crisis, the health and care system have been able to access COVID monies or funding related that is more specifically related to COVID, and so we've been able to access those funds that have been allocated, nationally to local systems, and we expect to have. We've got similar arrangements in place for the rest of the financial year. However, it's always going to be a finite resource. So what we have to also look at is existing resources, how they can be adapted, how they can be more agile to respond to the ever-changing picture, really. In addition to this, I think what we have also got is, from a mental health point of view, Nhs Long-Term Plan is one of the most progressive policies around mental health, I'm pleased to say. And, as a result of that national policy, CCGs are expected to receive additional funding from next year for community mental health teams and also for crisis support services. And so those additional fundings that will come in from next year over the next 3 years, so the funding starts next financial year, but over the next 3 years, will also ensure that we have more support services, more capacity in the future. But at least in the short to medium term, we have got those arrangements in place that where we can access the COVID funding. Although having said that, I would say that the overall the system is financially challenged, and so we've got to continue to look at existing resources and how they can be more innovative and more flexible going forward.
Thank you. I noticed, Caroline, thank you, Karen Townsend, I put in the chat that actually digital has helped some people who don't like going face to face. And it swings around about. So some people, it's actually better to be on a screen and not have to travel somewhere, and it actually brings down the barrier. But it is about addressing the needs of each individual, isn't it? So thank you for that. Councillor Lay, did you want to come back on any of that?
Yes, just I would say exactly the same. I think I quite like using digital.
I do.
I don't have a problem, but it's not for everybody, as we all recognise. Could I just ask one very specific question of Caroline? In her report on page 22, I didn't know whether page 22, Caroline, under section 3.31, your first bulletproof says that and this is around the collaborative principles, work together to practically make a change to wicked issues facing the system. I didn't quite, is that a misprint, or what are wicked issues? WICKED. And I didn't quite know what that meant.
Councillor Lay, can I come in, because that I may have used the word wicked issue a couple of times in other forums. So sometime I will use that term. So in terms of mental health, we have some real challenges. So delayed transfers of care historically have been a challenge in Leeds, although we've had some recent success. And also, we mentioned earlier on some of the inequalities relating to some of the BAME groups, as well as have been around for a very, very long time. And often these issues, these complex issues, so I may have referred as a wicked problem, but that requires a system a system solution, so system coming together, and it's beyond one organisation. So it's possibly that's the context, is to bring providers, commissioners together to look at some of those key complex issues that I've probably described as wicked. I hope that makes sense.
I think Councillor Charwood, well, I know that she put in the chat that it's a thing that, you know, traditionally was too hard to kind of, but wanting to tackle it together. So yes, when words are used in different contexts of how I normally use them. Before I bring in Councillor Trustwell, and I've got Councillors Trustwell, Latty, Reagan and Knight. Naomi, did you have to leave at 3 o'clock?
I do, yes, Chair.
Yes. I'm just wondering if there's any questions for Naomi before she needs to leave at 3 o'clock. If you could indicate, please. No, that's it. Well, before you leave, thank you for being here, and thanks for all the work that has been done. So really appreciate it. So I'll bring in Councillor Trustwell then, please. Thank you for waiting.
Yeah, thank you, Chair. I hope my questions won't be too wicked. It seems that quite a while since we were discussing the presentation on COVID, but my first question is about how mental health figures in the overall COVID debate, for want of a better expression. Because I'm becoming increasingly concerned that when people talk about COVID and the measures that have been taken to try and restrict its development, mental health gets put in the other side of the equation with the economy as one of the considerations to be taken into account in terms of just how stringent the measures are to control COVID. Now, I understand that if you lose your job, you lose your income, you're in overcrowded accommodation, you can't socialise, you're a victim of domestic abuse. I can understand those wider considerations. But I'd just like the views of officers about the mental health elements of COVID itself, which kind of balance out that seesaw. So I'm thinking about, you know, people now living with what's called long COVID, with the impact of bereavement where people have lost loved ones from COVID, from the anxiety of people, especially those in BAME groups, in older groups, those with underlying conditions, the anxiety they feel as they see the rates increasing, those who are awaiting physical treatments but are in pain and developing, you know, mental health responses to that. I suppose it's a plea for saying that when we talk about mental health in the context of COVID, we don't pile all those considerations on the other side of the seesaw, and that there are mental health considerations when you talk about COVID. So that's my first observation and kind of general question. Moving on to the strategy, I think that this strategy is really coherent, and I welcome it as someone who's been involved with mental health issues since I was first elected in 1982, and we still had institutions like Highroyds with 2,000 patients in and a very impersonal service. We've moved a very, very long way. We've closed those establishments. We've got more community support, more preventative support. But I suppose the slight skeptic in me is that over that time, I've seen so many strategies. Every cohort of officers and members of all authorities over that time have produced strategies, and they've all had the same components, whether it's been about addressing the overrepresentation of BAME communities, about co-production, about collaboration, about co-commissioning, about single point of access, the list goes on. They've all been components of that. So what is so special about this strategy? Is it going to be the mental health strategy to end all mental health strategies? Moving on really quickly, Sandy's covered the finance stuff, so I'm not going to go into that. There is a figure quoted on page 16 about the cost in Leeds of mental health issues at £500 million. How is that figure calculated? Because we often see these global figures thrown out without the methodology behind them. And I suppose, just to cut short, we've had a suicide strategy now for some while, and that's something that, again, we praised the collaboration around. what impact is that having? Because obviously the point is made that the strategy is not just suddenly fallen from heaven, it's bringing together a lot of existing strands. And so I'm just wondering whether we could have just a few comments on how we're progressing with the suicide strategy. Is it yet having any impact, or is that a more longer term measure? And sorry, I have one final question. There are a lot of outcome measures, which is really good to see because we need those. What is the baseline going to be? Is it going to be last year's figures, this year's figures when they're available, next year, or whatever? And I do appreciate that it's going to be very difficult because we're living in difficult times. Thank you, Chair.
Thank you very much. I know that Sam has to leave at 3 o'clock as well, so I just want to publicly thank her for her input and her detailed answer to the questions. Okay, so there was, I don't know who wants to go first. Cash, you've got your microphone off, so do you want to tackle any of those questions?
Yes, so I will invite other colleagues to also make comments as well and their views as well. Okay, so in terms of the question around the strategy and why will this be special and how will it achieve the impact it needs? Because we've had, like you say, Councillor Trustwell, that we've had previous strategies. I think, I mean, I've worked in many different health and care economies. I have to say that Leeds, I think the strategy, the priorities have been co-produced, and they are very much evidence-based in terms of where we need to focus our energies on. And I think the approach that we've taken is to have a senior responsible officer for each priority area and ensure there is a clear work stream, a clear measurable project plan or delivery plan with some with clear baseline and also clear outcome measures. And so that approach that we have put in place, I believe that that's going to really ensure that we're really outcome focused, because the reality is that we can do lots of work and not shift not make impact on the outcomes that we want to see as a system, on a population level. So we're going to utilize all of the kind of expertise in the city around business intelligence, around data needs assessments, to really help us to ensure that we get the correct measures in place. And every year we refer back to say, what progress have we made? And so that's the approach I think we will take, and I'm sure the colleagues might want to add more to that on that particular question. In terms of the finance question, I think in terms of finance, it'd be, I mean, we can overall, there is a significant investment in mental health.
Yeah, Cash, you've covered the finance bit. I was happy with that response.
Are you happy with that? Okay. Okay, that's fine. So I've done finance. The other question, which was a general point you made around COVID and the challenge, and how's that being treated around mental health. I think I can only speak around Leeds, and I think Leeds mental health is a high profile. It's on, I think there's, we recognise that impact of COVID, the mental health is going to, the demand and needs are going to increase. So whilst I recognise that historically mental health has been perhaps not received the attention it needed, but from a local Leeds system level, I believe that the arrangements we have in place, the relationships we've got in place, very much ensure that mental health will be at the forefront of any responses we've got overall around the pandemic. And the presentation that we've presented kind of highlights the wide, broad, the breadth and the depth of work that's happening in the city. But what I would say is more needs to be done. If we are really, we are very clear that the increase is going to increase, the demand's going to increase, and therefore we do need to ensure that we've got robust plans in place for the next 6 months or longer. So that's just my perspective. I'm happy for others to come in. Alison may have a view as well, and Caroline, Barry, in terms of the strategy as well.
Okay, I'll continue with the COVID part of the question, if I may. There has been some very specific guidance produced by NHS England in response to COVID and the impact of it on mental health. We have been given directives around ensuring that we are targeting services at particular kind of areas of the population. And that includes those who have been bereaved by COVID. And I can say within Leeds and across West Yorkshire, we have set up bereavement helplines that are accessible to people. So it's the impact of the bereaved, it's the impact on carers as well of looking after people who have had COVID. And we've been asked specifically to address the psychological impact of people that have been in intensive care for periods of time because of COVID, and also the impact now of long COVID on people. And also, we mustn't forget the psychological impact on the staff in the NHS who've been caring now for a prolonged period of time for these people in quite difficult circumstances. And, we're now entering a second peak, it would seem. So as well as recognising the level of anxiety that's caused within the general public and making provision for that as well. So these are the specific areas that have been recognised in kind of national policy that we're then being asked to look at how we apply that locally. So I do know, for example, that the health psychology team at LTHT have been particularly focusing on people that have been in intensive care and the staff. There are groups that our psychologists are involved in a West Yorkshire group about looking at provision of support for staff, etc. So those are just a couple of examples. There is an awful lot of work going on that is addressing that impact of COVID on mental health. In terms of the strategy, I think Caroline summed it up in the chat beautifully about this brings together in partnership in a way, brings people together in a partnership in a way that we've not done before in Leeds. And I think it will be very powerful, a very powerful structure and process to implement change and improvement. And I particularly wanted to pick up your comments around the suicide strategy. The suicide strategy, and unfortunately we don't have any colleagues, I don't think, from public health on the call today. But the working on the suicide strategy has been continuing. It does appear that we have seen some areas of the population, sadly, rates increase during the pandemic. But generally, the impact of the suicide strategy that's been coordinated across West Yorkshire is making a positive impact. I've just seen a comment there about Victoria's on the call, so yeah. I'm going to hand over to Victoria because much more expert at this than I am.
If you don't mind, Victoria, coming in on that, and then Caroline Barrier, you had your hand up, you'd like to make a comment. Hi, Victoria.
Hi everyone, I'm really sorry I joined the call about 30 seconds ago, so I'm sorry if I've missed the train of...
It's about the suicide, it's about the Councillor Trustwell asked about how suicide is fitting into, and that we have a suicide strategy and how that's...
Well, Chair, from Victoria's point of view, and I hate to repeat myself, but to some extent, I was hoping that I saw Victoria was on the call previously and I didn't realise that she'd kind of gone out and come back in. I think the point I was making, Victoria, was not just about suicide, it was the way we view mental health in the debate about COVID prevention and restriction measures, that all too often we have the COVID on one side, its impact, the numbers, the deaths, etc. And on the other, we have the factors that are used to suggest we need to moderate the COVID restrictions, and mental health is often quoted in that. Alison has given a really good response, I think, to that, in that, I asked the question about mental health purely from a COVID perspective, and Alison has touched upon most of the points, around long COVID, around bereavement, around all the others. So really it was a plea that when we're talking about mental health in relation to COVID, we don't just put it on one side of the seesaw with economy and things, but we actually address it as part of COVID itself. Because I'm wondering, I'm just fearful that we're getting out of kilter in that debate about the need for stringent measures, and the longer this disease is embedded in our community, the more the economic and mental health issues will be perpetuated. Sorry, it's a bit of a rant, I know, but that was the context of my question.
Yeah, and this paper was looking at the effects of COVID on mental health, and it causes more problems in terms of, and we already had enough that were being addressed. So yeah, thank you, Victoria.
Yeah, sorry, and just briefly, because you've obviously had a longer discussion about this, I'd just like to fully support those points, Councillor Trustwell, and all of the conversations we're having around not just restrictions, but the whole approach to our management of the pandemic. It does feel very healthy, the Leeds system conversation about that at the moment. We're talking much broader in terms of health harms around the pandemic, not just about suppressing the virus. So clearly some of those health harms are mental health, and some of those will be immediate around people who feel very isolated, with current restrictions and potential further restrictions. But we know some of those impacts are, much longer term over the following months and years, with the impact of any economic, issues created by the pandemic. So we're working really closely with NHS colleagues too around their perspective on mental health harms, not just from an economic perspective, but from a broader perspective. So there's very much kind of a joined up response across the Leeds system around this with health colleagues. So I would really want to continue to promote that and support the points you've made.
Thank you. Before I bring Caroline in.
Thanks, Chair. Before you do that, I'm quite happy to get an email about the methodology for calculating the £500 million figure.
Oh, thank you. Yeah. Yeah, that'd be good, because it might bamboozle me anyway if it's just if somebody does have that at their fingertips. In terms of Kath Roth makes a point in the chat that national government has a role in creating conditions for good mental health, in terms of our jobs, affordable housing, living wage, and that we can only do so much, can't we, in terms of our strategy. But Caroline, would you like to come in? Thank you.
Thank you very much, Councillor Hayden. Yes, I just really wanted to touch on the point. I think it has been covered, so not to dwell on it too much. But why this strategy? What difference is this strategy going to make? I think it's really a significant point to make that this all-age strategy is not just focusing, as previous strategies have done, on current statutory services, on crisis support, but actually very much looks at wider determinants, what's called wider determinants, and the whole impact of lack of access to good education, training, to employment, housing. So we've brought together in this strategy a recognition of the importance of support to people to maintain good mental health and promotion of good mental health, as much as focusing on what we put in place to address mental ill health. So that is really quite a significant difference in this strategy, because it's around avoiding people having to hit crisis before they're provided with the relevant support mechanisms, and not just service-based, but good mental health support to prevent escalation of mental ill health. And the only other thing I wanted to add was certainly pre-COVID, central government had recognised how important it was that we couldn't just ask for mental health to be addressed without putting additional funding in, and the NHS was allocated additional funding to support people in mental health, and again to maintain good mental health. So all the sort of upstream stuff to prevent the need for people's needs to have escalated and hit crisis point. And this strategy, as much as focusing on the sort of crisis and high-end support, also focuses on how we can help people to maintain good good mental health, and that is, I think, a significant difference, and with the right input from wider range of stakeholders, I think we can work towards that.
Thank you very much. Councillor Latty has put in the chat that his question has been answered by the responses to Councillor Trustwell's question. So thank you for that, Councillor Latty. So I'll bring in Councillor Reagan, and thank you very much for waiting.
I think some of my questions have been answered, but I'm just going to raise the issue again. I cover Bermontoft, Richmond Hill, which is one of the most deprived and uneconomic areas of the city, and it's got an increasing amount of BAME people in that are in the hospitality sector, of which is being hit at a rate of knots with losing jobs and restrictions. Now, I'm really fearful that not only Bermontoft, Richmond Hill, but all the inner city areas are going to have this increase in health and well-being and mental health from people that are suffering, not getting their, having their jobs taken away and not having an economic well-being to sustain their families and their own lives. So how is the mental health strategy working with that? And because I think as well, it doesn't have all the people in those areas are accessible by digital. Yeah, I think it's a fantastic issue about digital, but a lot of our communities don't have access to that digital means. So we have to look at a strategy of how we're getting into that grassroots issue before it actually comes to fruition, don't we?
Thank you. Who would like to pick that up?
I'm happy to come in again, Councillor Hayden, if that's okay.
Yeah, that's great. Thank you.
Yeah. So again, I think this is the focus on or making sure that we've got our sight on and are refocusing around how we can do our level best to support our communities at a time when there is quite significant risk of people losing their work, their paid employment. As you know, we've got a strategy or a focus on skilling people and getting people back into work. And one of the strands of the mental health strategy, one of the 8 priorities, is around access to paid employment. Obviously, we developed this strategy through huge consultation well before we had the COVID outbreak. The COVID pandemic has just compounded the problem around employment and support to meaningful and paid employment. So we just recognise that we've got to do our level best to support whatever we can to get people back into employment. But as Kath has already noted in the chat, this is a much wider issue than something that just the mental health strategy is going to be able to crack.
Yeah. Definitely. Thank you for raising that, Councillor Reagan. It's a really important point. And finally, and thank you so much for waiting, Councillor Knight, if you'd like to ask your question.
Thank you. Yeah, my question is around helping people in the workplace. Now, since lockdown ended, a lot of people have been encouraged to go back to work, shall we say, forced in some cases to go back to work, despite the fact that previously they were shielding. And this has been one of the main causes of anxiety for a lot of people. The fact that they now have to go to work in places where they're not sure it's really COVID safe for them, etc., etc. Whether it is or it isn't is not really my point. My point is the anxiety that is causing for people. And I know that pre-COVID, we were providing training for mental health first aiders in the workplace. And it seems to me that's even more important and relevant now. And it would be a way of targeting lots of people or giving people access to some kind of mental health service. So our first question is, how's funding and resources been able to, have you been able to channel more funding and resources into training mental health first aiders perhaps, or any other means of getting this service into workplaces? Has it been widely publicised, so people are aware that they can do that? And would a mental health first aider be able to refer somebody on if they became aware that the person they're dealing with has issues that are beyond their own skills to deal with? Can they refer elsewhere? Okay, yeah, thank you.
Thank you. Who's best placed to answer that one about in the workplace? Cash, thank you.
So I think in terms of first aid mental health training, what we have is we have a program of work in terms of first aid mental health training, assist training. This is these are preventative measures or schemes in place just to improve the mental health and well-being of our citizens. As part of the reset work, as part of the work of resetting services, this is one of the key discussions that we've had as part of our reset work, where we want to explore opportunity to expand the work. So what we've already got is really good, but how can we actually expand and actually provide further investment into this type of work, which is even more needed as a result of the impact of COVID. At the moment, that proposal is being developed by our public health colleagues, and it will be coming to the mental health oversight group for a decision about in terms of funding and how we can potentially prioritise that. I think there's a clear consensus to support more preventative types of schemes. So that is very much a live discussion topic, and we're all very supportive, and I'll be able to communicate a decision in the next couple of weeks around whether we're able to source the funding for that particular scheme to expand further. In terms of just also would like to add to this is that you're absolutely right in terms of the anxiety, the increased anxiety levels are within the population. Leeds CCG have made a significant investment in our IAP service. Potentially that's it's a significant service in terms of offering psychological interventions for people experiencing anxiety, depression, low mood, and other common mental health conditions. People can access that either through self-referral or through GP or through other means like digital platforms and also Mindwell. So there are opportunities to access those types of intervention and support. In addition to that, we are very much aware of that some of our prevention schemes need to scale up, and those are being considered and will go through the right governance to seek approval around that. Just want to check if anyone else, any other colleague of mine would like to add anything further.
Victoria's added into the chat that as a council, we commission Leeds Mindful Employer Network to support best practice of employers in workplace mental health. So there's that network as well. So, yeah. Okay. Thank you very much. That was a very long but very productive and interesting and vital discussion. It's incredibly important. I just want to thank everybody for your inputs. Everyone's been really engaged, and I was just thinking at one point it was like a video game. There was hands going up all over the place. I couldn't but it really, really appreciated. So thank you all very much. We're moving on to the budget. So if NHS colleagues would like to leave the meeting now, then you're free to do so. And just a huge thank you to Cash and Alison and Caroline, and I'm hoping I'm not leaving anybody out. Sam and Naomi have already gone. So so thank you so much for being here and part of this really vital discussion. I really appreciate it. And hopefully we'll have some follow-up on the figures that Councillor Trustwell talked about, and some interrogation of the data that Councillor Brooke talked about in the centre of Leeds there, and our student and city centre populations. So thank you. So and we'll see you again soon, I hope. So moving on to item 8, the revenue budget update 2021-22, and budget savings proposals. So we all received the report to provide members of the Scrutiny Board with details of the latest revenue budget update and budget saving proposals as considered by the Executive Board at its meeting on the 24th of September 2020, and those are the papers that we'll be discussing this afternoon. The Scrutiny Board did hold a separate working group meeting on the 5th of October. However, the board is now being asked to formally consider, review and comment on matters and proposals relating to service areas that fall within the Scrutiny Board's remit. Other Scrutiny Boards are considering elements of the budget savings proposal relevant to their terms of reference. It is important to acknowledge that further savings proposals are expected to be brought to the Executive Board over the next couple of months, and so all Scrutiny Boards will continue to be consulted and as to share their views, and we will be discussing another working group in November. So and it's suggested that we meet on the 20th, those who can, on the 20th of November 2020 at 12 p.m, and Angela has proposed that for this meeting to discuss any further developments. Any comments and recommendations that are made by this Scrutiny Board during the consultation process are to be captured within the composite report from Scrutiny to be submitted to the Executive Board for its consideration. So can I ask Kath first to introduce, if that's okay, Kath Ross, and then we'll to introduce the report, and then we can go to questions on it then afterwards. Thank you, Kath.
Okay, this is going to be the start of a number of conversations I'll be having with Scrutiny Board, but this is our first tranche of savings proposals. As much as possible, we are trying to do things that is either around improved efficiency, extending our strength-based approach to practice, ensuring that the cost of care falls to the appropriate agency, and anything we can do through more efficient business processes. So that was the sort of philosophy of our approach. Probably the most accessible way of looking at the savings is what's summarised in Appendix 1 of the Executive Board report. So you will have a landscape table line by line. I think probably the best thing to do is, first of all, say, are there any questions of clarity or clarification from Scrutiny Board members, just on what's the information, so you understand what's put before you, and then any further questions about why this, why not something else, perhaps is the best way to deal with the item.
Okay, can I invite anybody that might need questions of clarity or on the table? We did have quite a discussion, quite detailed in the working group. No, I don't think there's any questions for clarity on that.
Well, in which case I'd probably take more general questions then, because I mean they are what they are really, and it's questions or comments from Scrutiny Board members.
Absolutely. We seem to have all gone quiet on this now. Is there anybody else because we that wishes to make any comments or questions on these savings proposals? No. Okay, so
with teams and so on.
it
so COVID-19 sort of came about, we reflected back on what
I seem to be getting the news or something. Is that kind of
shows the transformation that we went from written intelligence.
the mics, please? Thank you. If you're not speaking. Right. Thank you very much. We have. So there's no questions, Kath. I don't know whether any other officers want to come in and talk about the, or do we just go to making the recommendation that we take these savings proposals? Councillor Harrington.
Sorry, I will get there in the end. Just on the section on staffing implications, Kath, it's talking about manage the staff reductions policy, and that there's been quite a high uptake on those wanting early retirement, etc. How are we going to manage the expectations of people that we still need to retain people with the requisite experience, so that we don't lose people at the top end of experience and be left with people who are very new to the job and don't actually have that experience ongoing? Unless that's maybe not your area, but...
Oh, no, it is absolutely my area and my leadership team's area. There is a balancing act to be struck. So while we are trying to let as many people go as we can to help out with the council's situation, we have made it very clear to our staff that requesting ELI is not an automatic right, and it has to operate on a case-by-case basis, both of the business case of that individual, so is it affordable and makes financial sense to let them go, but also do they play a key role that I simply cannot allow somebody to leave. And there have been individuals where that has been those circumstances and we've had to decline somebody's ELI. We are looking at skill mix, we are looking at service continuity, we're looking at service resilience, and it's sort of a rounded judgment that we are making. So while we will have a number of people going on ELI, equally we will have people who we are retaining in the service because of their skill, experience or unique skill set.
Thank you. I've been gone through that process in my previous job. I know how difficult it is when you're offering that and then lots of people want it, but actually trying to maintain that balance is very difficult. So I don't envy you.
It is a balancing act, isn't it? Because you could be left in a situation where your experience goes, and yeah, we're in a worse. Well, I mean, we're in a pretty bad situation anyway. Okay, right. So, should we go to that? We are accepting of these proposals. If I've got no other questions. I'm wondering, now we've got Councillor Rafiq on there and Mark Alman from Active Lifestyles. I just wondered if you wanted to say anything, Councillor Rafiq, and thank you for being here this afternoon. There you are. Hello. You'll have to unmute yourself. Oh, you're still muted.
Start again.
There you are. Yeah, thank you.
No, I'm just here for the, as you've said, for the budget part of the discussion relating to my portfolio with Mark to answer any questions colleagues have. It is a very difficult and challenging time for the council, and we are having to make some decisions which are very difficult and something we wouldn't do under normal circumstances. but everybody knows, you know, this is something we've never faced, or you know, the challenges we have at the moment. So these are unprecedented times. So happy to, I don't want to go on for too long, happy to answer any questions or concerns members have around, you know, my part of the portfolio in terms of budget.
Thank you. Would you like to add anything, Mark, about the financial? Because I know that you've been, it's been really good over the last 6 months that I've had regular updates every 2 weeks. At one point during the lockdown from Mark and both myself and Councillor Rafiq. But it's been really challenging for your part of the service. So.
Yeah, it's been really difficult, but obviously we've got some quite challenging proposals that are now being in the public domain and going to exec board tomorrow. So I understand we'll be having a conversation at the next Scrutiny board meeting in November. I mean, suffice to say, I mean, it's all about having a conversation on the back of the proposals. As I said, none of them are decisions or proposals that we taken lightly. But you know, the grave position that councillors with the budget, we're having to consider things that we really wouldn't like to normally, but it is what it is. So I know it's the start of a conversation as well. So we need to consult on those proposals, and I don't want to preempt anything from executive board tomorrow, really.
Yeah, thank you very much, and thank you to if you pass on to your team as well in Active Lifestyles and all the leisure centres, and how fantastic they've been over the last 6 months in their versatility and adaptability and resilience. They've been fantastic. Okay, so we'll take the recommendations and agree the recommendations from the report, and then continue this conversation in November. And thank you to everybody for the report and for all the work done on this on the budget. So if it's very challenging and very difficult for everybody, and making those decisions that you don't want to have to make. So thank you. So we'll move on to item 9, which is the work schedule. And if officers would wish to leave, then that's absolutely fine. So can I invite Angela to speak to this, please?
Thank you, Chair. So within this report, this asks the board to consider its work schedule for the remainder of the municipal year. So the latest version of the work schedule is set out in Appendix 1 for consideration. This is to be updated to incorporate the budget consultation working group, which is scheduled for the 20th of November. Board members are also reminded that there is a working group meeting scheduled for the 3rd of November at 1 p.m. and this is to complete the outstanding piece of work from last year in relation to the Airborough Leisure Centre renovation project. A summary note of that working group's meeting will be brought back to the board's next formal meeting on the 24th of November. And at that next meeting, the board will also be receiving the annual report of the Leeds Safeguarding Adults Board, as well as an update on the work that's been undertaken to promote healthy and active lifestyles across the city. So members are now asked to consider and agree, or to make any further suggested amendments to the board's work schedule at this stage. Thank you, Chair.
Thank you very much. So any comments on those proposals going forward? It's going to be busy in November. But everyone's a bit busy now. Right, so we'll take those as being agreed. So the next, the date and time of the next meeting of the full scrutiny board is Tuesday, the 24th of November at 1:30, pre-meeting for all board members at 1 o'clock. And then we have the working group meeting for Airborough on the 3rd of November. So as many people as can, and Councillor Latter, you will be there with your Guiseley and Rawdon colleagues as well. And I know that Councillor Lay, you're very interested in that situation as well. So that's on the 3rd of November. And then the budget working group, as Angela said, on the 20th of November, just before a few days before the full scrutiny on the 24th. I don't know what the world will look like by then, so we'll have to just wait and see, won't we? And I don't know about anybody else, but I'm taking each day as it comes, and I'm getting through today, and then we'll deal with tomorrow when tomorrow comes, because it's all very trying time for a lot of people. So thank you for this afternoon, for your excellent questions on the mental health strategy and the COVID, the impact of COVID, for your patience, for your intelligence and just interest. It's, you know, I really do have the best scrutiny board on the most important subject. So thank you very much and enjoy the rest of the evening. Take care. Bye-bye.